Hello friends, this is Dr. Ganga, your nephrology educator at Prep Ladder. So today, let us continue the discussion that we had from vasculitis 1. So this vasculitis are divided into two topics because it's quite large. So this part I'll call it vasculitis 2. In this part, mainly I'll be dealing with the KDIGO guidelines of management of vasculitis and also other vasculitis, medium and large vessel vasculitis like Takayasu, Kawasaki disease, polyarteritis nodosa. So let us get into the contents. So we'll deal with the KDIGO guidelines for management of ANCA vasculitis. In that, we learn the approach to management, definitions, frequency of organ involvement, histopathological classification, prognosis, treatment of ANCA vasculitis, trials in the induction therapy of ANCA vasculitis, what is induction therapy per se, what are the trials of plexin induction therapy in ANCA vasculitis, what is maintenance therapy in ANCA vasculitis, and what are the trials in maintenance therapy. Okay, so all these are the things. Apart from it, other large vessel vasculitis like medium vessel vasculitis like polyarteritis nodosa, Kawasaki disease, Takayasu arthritis, giant cell arthritis. Finally, I'll end it up with quick revision where I brush upon all the topics or questions which have been asked in previous entrances. Okay. Now coming to the broad outline of management of vasculitis according to KDIGO. So if you suspect any patient has kidney vasculitis, you see if the clinical presentation is comparable with vasculitis, that is PR3 or MPO positive disease with low suspicion of secondary vasculitis like any immune complex vasculitis like we discussed in vasculitis 1, which might be SLE, rheumatoid arthritis or associated with IgA or cryoglobulinemia. If that is the case, then you have to refer the patient to experience center. When you are the nephrologist and you are present there, you yourself placed as an experience center. Okay. And commence treatment, biopsy soon after starting treatment when feasible. So this is an important point. Okay, it says you can wait for biopsy. If the clinical condition is compatible, ANCA is positive, then start treatment. Don't wait for biopsy because many a times patient will be volume overloaded or patient might be having pulmonary hemorrhage and you might not be in the state where you can do biopsy immediately. So don't wait for treatment to do that. What KDIGO says is start treatment and do biopsy whenever it's feasible. Okay. Now, if clinical presentation is compatible with any primary small vessel vasculitis, if clinical presentation is incompatible with any primary small vessel vasculitis, which might be PR3 or MPO, then you go ahead and do biopsy. If there is no contraindication for biopsy, biopsy. So this flowchart simply says, if it is ANCA vasculitis, you go ahead, treat the patient, and when possible, do biopsy. If it is not primary vasculitis, that is not ANCA vasculitis, then you, if compatible, do biopsy first, then consider treatment. Okay, because this can be because of any secondary disease. Simple. Now coming to the next thing. See, the same thing repeated. Features compatible with small vessel vasculitis, then biopsy is not needed for starting immunosuppressive therapy. Okay. Now, coming to the definitions, before getting into the disease, we have to know certain definitions that are coined by KDIGO, which will help us in understanding the disease and how we have to label each patient. So first is disease activity of ANCA. So what is disease activity of ANCA? It means there is associated vasculitis symptoms or signs, okay, which can be attributed to vasculitis. It might be affecting any organ or system. So disease activity means active disease is present in any organ or any system, and this can be attributed to ANCA. Second is remission. Remission is defined as absence of manifestation of vasculitis and glomerulonephritis. So in any situation, if the patient is going into remission, it means there is no manifestations of vasculitis or there is no manifestation of glomerulonephritis. Now, for glomerulonephritis, it is defined as a stable or improved glomerular filtration rate and proteinuria may be persistent. So now, how do you know that there is no disease activity in the kidney? Generally, in other diseases, if you see, proteinuria will be taken as a marker. However, here proteinuria will be not taken as a marker because proteinuria may be persistent. So any improvement in glomerular filtration rate is what is taken as a marker. Now coming to the next thing, which is relapse. Relapse is increased disease activity after a period of remission. Okay. Now this relapse can be either major or it can be minor. Major can be with following examples, okay? Like it can be alveolar hemorrhage, it can be subglottic stenosis, glomerulonephritis, or vasculitis threatening vision. So any major involvement like lung involvement, kidney involvement becomes major. Minor can be something like a sinusitis, okay? So that will be minor. So relapse is after a period of remission when the disease comes back. Treatment resistant disease is defined as persistence or appearance of kidney disease or systemic manifestation of vasculitis while receiving treatment equal in intensity to initial immunosuppressive therapy. That is, once the disease has come back and you give an immunosuppressive therapy to which the patient has responded the first time, even then the response is not seen, it's treatment resistant disease. See, among all these four, the important thing for you to remember is remission is not assessed in terms of proteinuria and vasculitis, okay? The rest of the things is okay. No one is going to ask what is relapse in ANCA, what is remission in ANCA. All this is generally for clinical uses. This is the same table. This is but reproduced from the KDIGO guidelines 2021. So it is almost the same thing that we discussed last time. So cutaneous involvement, there we have discussed both IgA and cryoglobulinemia along with 3 ANCA vasculitis. So here cutaneous involvement is more common in EGPA when compared to GPA and microscopic polyangiitis. Kidney involvement we know is most common in microscopic polyangiitis. Similarly, lung involvement is more in vaginous or GPA. Ear, nose and throat involvement is more in vaginous or in GPA. Musculoskeletal involvement is equal in microscopic polyangiitis and granulomatosis. Neurologic manifestation is more in EGPA. Gastrointestinal manifestations are more in EGPA. So if you see, cutaneous, neurologic and gastrointestinal manifestations are more common in EGPA or Church-Strauss. Pulmonary, ENT and musculoskeletal are more common in GPA or vaginous, and kidney involvement is more common in NPA or microscopic polyangiitis, okay? Now coming to the histopathology classification, this also we had discussed in the previous section, that is vasculitis 1. So based on the histopathology, this will be classified into 4 classes, okay? If more than 50% of glomeruli are globally sclerotic, then it becomes sclerotic class, okay? This has worst prognosis, okay? Sclerotic class has worst prognosis. Then if more than 50% of glomeruli are normal, that is only 50% of glomeruli have focal involvement, then it is called as focal class, which is best prognosis, okay? Then if 50% of glomeruli have crescents, it's called crescentic class. This class has somewhere intermediate prognosis, and then come mixed class, okay? So if you consider mixed class has more worse prognosis than crescentic class, but remember the best prognosis is focal and the worst prognosis is sclerotic. Now coming to the prognosis, okay? So kidney recovery can happen even in advanced histological stages. So do not withhold immunosuppression in any patient based on the biopsy report. Maybe you will find it is sclerotic, or what way, maybe you will find it is focal. So based on the biopsy finding, we do not treat ANCA. If it is ANCA, we are going to treat, because even in advanced stages, they respond to therapy. Sometimes patients with ANCA negative becoming ANCA positive can help us predicting relapse in the disease and persistent positivity. However, persistent positivity will not help us in taking treatment decisions. So this is the problem with ANCA that we even saw in the previous session. So ANCA can be a moderate level of marker to show that the disease is present. However, its persistent positivity will not help us making treatment decision, unlike in anti-GBM, where till anti-GBM became negative, you were doing plasmapheresis. However, here, once it's positive, you are not going to remeasure it to decide, make treatment decisions, okay? And another significance of ANCA is ANCA PR3 has more relapse than MPO. So, if you're using ANCA for prognostic values, you should understand its limitation. And next, you have to know that if ANCA PR3 is present, then the chance of relapse is higher. Now, treatment. Treatment is divided into 2 classes. First is induction and second one is maintenance therapy. This is like lupus nephritis, where we have induction and maintenance. Okay. Now induction, which are the drugs used for induction? You give glucocorticoids, which is pulse followed by 1 mg per kg, along with cyclophosphamide or rituximab. So these two are the things that can be done. Again, cyclophosphamide can be given either oral or it can be given intravenous. Okay. Now, if it is severe disease, that is creatinine is more than 4, then cyclophosphamide plus glucocorticoid has to be given. In that, rituximab, data for rituximab is not high when the creatinine is more than 4, or you can give 4 weekly doses of rituximab plus 2 doses of cyclophosphamide. This was tested in a trial called rituxivaz trial, and it was found that, I'll come to these trials later. So it was found that if you give 4 doses of rituximab along with 2 doses of cyclophosphamide, it was non-inferior to giving cyclophosphamide plus glucocorticoids. Now, these are the trials in induction. So, see, these trials, I have compiled what is the trial name and what is the outcome, which is the most common thing that is going to be asked in the entrance. Now, if you ask me, is it a must to know these trials? I would say no. But if you are aiming for that high rank, that single seat in some institute of your choice, then I would suggest you learn it up. This is the easiest way in which I have put it up. Even I would do that. I would put these trials in tables so that it will be easy for me to learn it up in the last moment, revise it in last moment. So, if you are aiming for the top 1 rank, I would suggest you go through and remember this table. Okay. So trials in ANCA vasculitis are classified into trials that happen about induction and trials that happen about maintenance. Okay. So the trials about induction, first is we'll deal about rituximab. So first is the RAVE trial. RAVE trial showed that by using rituximab, you find better remission in PR3 disease and in relapsing disease. But this was done in patients with creat less than 4. So in non-severe disease. Okay. That's what it means. In non-severe disease, rituximab when given is better in PR3 positive disease and in patients who are relapsing. Okay, so that is RAVE trial. Second is rituxivaz trial, which I just told in the last slide. So rituximab plus 2 doses of cyclophosphamide plus glucocorticoids is equal to cyclophosphamide plus glucocorticoid in severe disease. Okay. So you give 4 doses of rituximab plus 2 doses of cyclophosphamide. This is similar to giving cyclophosphamide plus glucocorticoid, even in severe disease. So this is second. Third one is Cyclops. So this is fully about cyclophosphamide. They found that outcome, whether to give oral cyclophosphamide or IV cyclophosphamide, the outcome was similar between both oral and IV cyclophosphamide. But there was a thing. IV is generally having lesser dose than oral. So relapse was higher in IV when compared to oral. So IV is lesser dose, right? So what is going to happen? Relapse is going to be more. So in IV dose, relapse is more. In oral dose, the dose is actually more than the relapse. Okay. So this is what was seen in Cyclops trial. Then NYCYC trial, that is mycophenolate, was compared with cyclophosphamide, right? It's from the name. So this was done in non-life-threatening disease. So their outcome was similar in cyclophosphamide and MMF group. Okay. So, but in the PR3 disease, when you used MMF, there was more relapse. So hence it can be used in MPO disease. So in MPO disease and non-severe disease, mycophenolate can be used. Okay. That is what this trial, MYCYC trial showed. Next is Pexivas. This is one important trial you have to remember. One important trial that created a lot of beliefs in the recent times. Okay, recent time is around 2 years. I'm not telling very recent, but 1 to 2 years. This created a lot of change in our practice. Okay, that's Pexivas trial. It's about the use of plasmapheresis in vasculitis, and it showed that plasmapheresis in vasculitis, here is the first part of that trial. I'll be discussing the second part of that trial when I come to plasmapheresis. But in the first part of trial, it showed that when GFR is less than 50, low dose glucocorticoid is same as standard dose regimen, because we used to give high dose steroid, that is pulse steroid followed by 1 mg per kg for 2 to 3 months, then we used to taper. So this trial showed that the low dose steroid is same as higher dose steroid when given in GFR less than 50. So because of this, a lot of steroid toxicity can be eliminated. Next was the Advocate trial, which is for the use of avacopan. This is a recent trial. So they might ask it as a one-liner that for what it was used. So avacopan, which is a oral C5a antagonist, when combined with any of these agents, can act as a glucocorticoid sparing agent. Okay. So the trials are Rave and rituximab for rituximab, right? Then you have Cyclops trial, which is about oral versus IV cyclophosphamide. Then you have MYCYC trial, which is about mycophenolate versus cyclophosphamide. Pexivas trial and Advocate trial for glucocorticoid. Pexivas trial is basically for plasmapheresis, but it also showed that low dose glucocorticoid is equal to high dose glucocorticoid when GFR is less than 50. And Advocate trial showed avacopan, which is an oral C5a antagonist. It can be used as a glucocorticoid sparing agent. Okay. Now, so this is the chart. Once you diagnose ANCA-associated vasculitis and you do disease assessment and you plan for induction of remission. So if it is no organ threatening involvement, you can consider MMF, okay? Or you can also consider cyclophosphamide plus steroids or rituximab plus steroid. But if there is vital organ or life-threatening disease with serum creatinine more than 5.7, you have to consider plasmapheresis, okay? Now, disease control on drug and they attain remission, you can consider switching to maintenance. Maintenance, there are two main drugs. One is azathioprine with tapering steroid. Another one is rituximab with tapering steroid, okay? So, azathioprine and rituximab are two drugs that are considered in maintenance. Now, coming back to induction, we told that glucocorticoid plus cyclophosphamide or rituximab, right? So, in which group of patients will you prefer rituximab? See, rituximab is generally a safe drug when compared to the amount of immunosuppression it causes, or maybe it's fertility issue or malignancy issue. So, in which group all this is important is in extremes of age group. So, in children and adolescents, you will consider rituximab. In premenopausal women and in men concerned about their fertility, that is a middle-aged group person coming with vasculitis who's concerned about their fertility, then you have to consider this. Third is adults, frail old adults. So, based on age group, these three important age group. Then I discussed in the earlier slide only, if it is PR3 positive and it's a relapsing disease, then you have to consider rituximab. Another thing is if glucocorticoid sparing is required, that is patient has severe glucocorticoid toxicity features, then you have to consider rituximab, okay? Now next is which group cyclophosphamide is preferred. Cyclophosphamide is preferred if the disease is severe, okay? That is serum creatinine is more than 4. And combination of 2 IV pulses of cyclophosphamide with rituximab can be considered, okay? This is the other protocol in rituximab trial. So you just remember, if creatinine is more than 4, then the data is strong for using cyclophosphamide and you use cyclophosphamide. Or if rituximab is not available in the situation, then also you can use cyclophosphamide. Now, so route of administration of cyclophosphamide. Okay, so we know it is IV and oral. The advantage of IV is it is less dose and more relapse, and oral is it is more dose while less relapse. Okay. So IV you will use in patients who have a more of cumulative dose already of IV and who have lower WBC count, that is who have any side effect of cyclophosphamide already, okay, and who have an infusion center ready to access and in whom you suspect that if you give tablet they are not going to come back, okay. So in whom you are suspecting adherence issues. Similarly, oral you use in whom the cost is not an important issue and in whom you suspect adherence issues and who have difficult to access infusion center. Okay. Now, you don't need to remember all this as of now. You can do all that while you're practicing. But remember the drugs. Oral cyclophosphamide, 2 mg per kg per day for 3 months. Okay. Only if there's ongoing disease activity, you will continue for 6 months. So, it is around 3 to 6 months. Okay. And IV cyclophosphamide, you are giving it at 0, 2, 4, 7, 10, 13. Okay. So, it's almost 2 months. And if the disease activity is continuing, then you give it for 24 months, that is 6 months. Then rituximab, you just give 4 doses, okay, or 4 weeks. So, it is almost 1 month is going to get over. If it's rituximab plus IV cyclophosphamide, you give this for 4 doses. Then you follow it up with cyclophosphamide 15 mg per kg at week 0 and 2. Okay. So this is 4 plus 2, that is 6 weeks. Then if you're giving MMF, you can give 2000 milligram per day, that is 1 gram morning and night. And with poor treatment response, you have to increase the dose. And with MMF, you might have to continue the induction phase for a longer time. Okay. Now, induction after 3 months, if there is no response to immunosuppression and if the patient is still dialysis dependent, then you stop therapy because they might not respond. Okay. Plasma exchange, this is very important. When will you do plasma exchange for patients? Generally, there are three important indications. When it is a very severe disease, that is creatinine more than 5.7, okay. Second is when lung involvement is there, that is pulmonary alveolar hemorrhage is there, that also indicates severe disease. And if you don't remove the antibodies immediately by doing plasmapheresis, the more antibodies are going to destroy the lung and the hematemesis is going to worsen, okay. Next is double positive disease, that is, we saw this in chapter of anti-GBM. If there is ANCA plus anti-GBM positivity, then also you treat it with plasmapheresis, but rest of the treatment is like ANCA vasculitis only, and it is not like anti-GBM. So here I would like to stress upon the fact that the prognosis of ANCA is better than double positive disease, that is ANCA plus anti-GBM, which is better than anti-GBM disease, okay. So, three indications for plasmapheresis. One is when creatinine is more than 5.7. Second is when the lung is involved, or third when it is a double positive disease. Now, there are two trials which were done to see the use of plasmapheresis in induction. First was a MEPEX trial which showed that there was improved outcome with plasmapheresis in patients with creatinine more than 5.7. Okay, so MEPEX trial showed that plasmapheresis is good. But when they came to Pexiva's trial in GFR less than 50, there is no use of plasmapheresis to delay ESRD, alveolar hemorrhage or death. So, but even if it is less than 50, they didn't choose patients with creatinine that are very, very high. Okay. So, the thing is, even though these trials are there and it gives conflicting results, we still use plasmapheresis in those three indications, like when creat is more than 5.7, when there is pulmonary alveolar hemorrhage, and when it comes in association with anti-GBM disease. Okay. Now, this is a steroid dosing in ANCA-associated vasculitis. This is a reduced steroid dose. Okay. Here you don't have to remember anything. Just the first week you're going to give a high dose, 50, 60, 75. The second week you're going to step down to half of its dose. Then you keep on tapering till you reach 5 mg at 4 months. Okay. So, important things you have to remember is 4 months you reach 5 mg. In the second week, you step down by 50%, okay. So, it was seen that in the low dose steroid group and in the high dose steroid group, the response was similar. Plasmapheresis in vasculitis, the indication, like I said, ANCA vasculitis with severe kidney disease. 7 treatments, how many you should give? 7 treatments over a maximum of 14 days. The plasma volume is 60 ml per kg volume replacement, and give albumin as substitution. We know when we do plasmapheresis, if you see the chapter on plasmapheresis, we can use substitutions for the plasma that is getting removed. So that can be either FFP or it can be albumin. So in ANCA vasculitis with severe kidney disease, what you do is you do 7 sessions over 14 days and you replace it with albumin because there is no bleeding. But if there is diffuse pulmonary hemorrhage, then you can't do alternate day. You have to do daily until the bleeding stops, and you have to replace albumin and with FFP. Here you have to give FFP because in plasmapheresis you will be removing some coagulation factors, and this removal can precipitate further bleeding. So you have to give FFP. And vasculitis in association with anti-GBM disease, this is like anti-GBM where you give daily for 14 days or till anti-GBM antibodies are undetectable. Now coming to the maintenance therapy. Now we know in induction therapy, plasmapheresis plus or minus, then we have glucocorticoids, cyclophosphamide or rituximab. In maintenance therapy, it is 2 drugs mainly, rituximab or azathioprine with low dose steroid. MMF is less effective in relapse prevention when compared to cyclophosphamide. So it is not given. In induction, it can be given in non-life-threatening disease. But in maintenance therapy, it was proven that even actually when compared to cyclophosphamide and azathioprine was found to be better. Okay, that was the Cyclozarin trial, which proved that Aza was better than Cyclo in maintaining remission and preventing relapse, and it was later found that Cyclo is better than MMF in maintaining the remission and preventing relapse. Okay, risk of relapse is higher in this group, that is if PR3 ANCA is more than NPO ANCA, if there is cardiovascular involvement or if there is lung involvement, that there is more hemorrhage, it's a severe disease, then relapse is common. Okay, so these are the trials in maintenance therapy. Main-Ritson trial has been asked. So apart from that, it's not very important, but 3 important trials. The Cyclozarin trial, I told you, it has not been asked much. So main-Ritsen 2 is there, and rituximab is there. Okay, all these trials are about rituximab versus AZA. Okay, so in main-Ritsen trial, it was shown that rituximab, when given after cyclophosphamide induction, is in comparison with AZA, and it decreased major relapse but not minor relapse. Okay, after cyclophosphamide induction, if rituximab was given, it prevented major relapse but not minor relapse, and it was comparable with AZA. In rituximab, what was done is, in relapsing disease, rituximab induction was followed by rituximab maintenance versus AZA maintenance, and it shows that reduction in this decrease in major and minor relapse. So in relapsing disease, rituximab is in relapsing disease, ritux induction and ritux maintenance was shown to be better, and it decreases in major and minor relapses. In main-Ritsen 2, what they did is, they used rituximab maintenance, and they showed that it can be given as two schedules. One is fixed schedule, another one is keep checking the CD19 levels at periodic intervals, and if it is hiking up, then give another. So the advantage of doing this is you will give lesser number of doses altogether. So these three are the trials: main-Ritsen, rituximab and main-Ritsen 2. Now, who are the patients with increased risk of relapse in AAV? There are three factors you can use to see who are the patients who have increased risk of relapse in ANCA-associated vasculitis. First is, you have to see the baseline factors, and then you have to see the factors after diagnosis, and third, you have to see the treatment factors. Okay, the baseline factors which can suggest that this patient has increased risk of relapse is diagnosis of GPA, okay, or vaginous granulomatosis. And we know that GPA has PR3 positivity. So PR3, okay. Then lower serum creatinine, more extensive disease, and ear, nose and throat disease. Okay, so we know these are all characteristic of vaginous disease, where ear, nose and throat is involved, and multiple organs are involved, and not just the kidney. And if it is PR3 disease and vaginous. Okay, so all these are the baseline factors. Next is factors after diagnosis. Once you make the diagnosis, history of relapse, that is previously if they are having relapse, ANCA positive at the end of induction or rise in ANCA, that is at the end of induction also, if ANCA is positive, we already have mentioned that we are not going to make any further treatment changes based on it, but we'll keep in mind that this is a patient who can go into relapse. Similarly, if ANCA is becoming positive again in your follow-up, which was negative, then that can show relapse. Treatment factors is lower cyclophosphamide exposure, or you had to withdraw the immunosuppressor because of some reason, or you withdraw glucocorticoid. So basically lower immunosuppression, glucocorticoid withdrawal. All these are factors, treatment factors, which can predict relapse. But in exams, the important things that are asked is PR3 positive disease and GPA. These are the things that can show relapse in, and upper respiratory tract involvement. These are the things that can show relapse. So this has been asked as a question. Okay. Now, maintenance therapy, we know rituximab, AZA and MMF is there. MMF generally is not used. Rituximab, two dosing protocols are there. 500 mg, 2 doses. Okay. At complete remission you give, and 500 mg you give at 6 months, 12 months and 18 months. Okay. So it goes up to 18 months. I am not going into the further details. Or AZA is generally 1.5 to 2 mg per kg. You start at complete remission until 1 year after diagnosis. Then you decrease it by 25 mg every 3 months. Okay, so at the end of remission, when patient achieves remission, you start azathioprine, and then you keep continuing for 1 year for the same dose, and then you start tapering it. Okay, so extended azathioprine at complete remission until 4 years after diagnosis. Okay, so this is till when the AZA therapy can be continued. Glucocorticoid should also be continued at 5 to 7.5 milligram per day for 2 years, and then slowly tapered down every 2 months by 1 mg. So you saw in rituximab that there is no need for steroids along with maintenance, but in AZA you have to give this patient steroids along with AZA. Okay. Now, in which patient should we use rituximab, and in which patient you should use AZA? So rituximab, like in induction only if it is a relapsing disease with PR3 positive patient, frail adult, glucocorticoid sparing, or azathioprine allergy. So all these are the things that will help us in choosing rituximab. This is like what we read in induction only, in which condition we use rituximab. Azathioprine is preferred when the IgG level already is baseline low, so you don't want to further immunosuppress the patient with rituximab and further worsen their immunity, or HBsAg positive, which can lead to relapse in the disease, or limited availability of rituximab. Okay, so all these three conditions you can consider azathioprine if patient is HBsAg positive or if IgG is already less. Now, how long will you give? Duration of AZA plus glucocorticoid is 18 months to 4 years. Okay, that is almost 1.5 years to 4 years you are going to give AZA plus glucocorticoid. Whereas duration of rituximab is 18 months alone, that is 1.5 years you stop, and there is no role for maintenance steroid. This is important to remember, that once you are giving rituximab in ANCA-associated vasculitis maintenance, then there is no role for giving glucocorticoid. Okay, methotrexate can be given for maintenance after methotrexate induction. Now, which are the other situations? One is relapse, in which you prefer rituximab. Other one is refractory, where you have to increase the steroid dosage, and if patient is on rituximab induction, you add cyclophosphamide. If the patient is on cyclophosphamide induction, you add ritux. Okay, and transplant should be done more than 6 months of clinical remission, and persistence of ANCA is not a contraindication. So that is important. Okay, ANCA, if it is persisting, it is not a contraindication, and more than 6 months of clinical remission, then you can consider transplant. Clinical remission alone is required. Okay. Now, this is the entire flow chart. If the patient has ANCA glomerulonephritis, consider non-life-threatening or organ-threatening disease, then you consider rituximab with prednisone, or 6 months of cyclophosphamide with steroid. If there is remission following rituximab, follow closely to detect relapse, and if there is relapse, you give rituximab with prednisolone. Okay, if caught early. If it's late, then it's cyclophosphamide. Similarly, if there is remission following cyclophosphamide, you have to continue maintenance with azathioprine, like how there you will follow maintenance with rituximab, here with AZA. And then if it's relapse, then same thing, you continue the same protocol. If it's life-threatening, you give methylprednisolone or plasma exchange with cyclophosphamide and steroid. Okay, treatment resistance with cyclophosphamide, you will consider adding rituximab. Okay, then they go into remission. So if it's life-threatening, you give plasmapheresis, you give steroid, you give cyclophosphamide, and this is the drug. Okay, now this covers about the small vessel vasculitis. Coming to medium vessel vasculitis, which is polyarteritis nodosa. So question about this also has been asked in the previous INISS. So polyarteritis nodosa, what happens is the main visceral arteries and their interparenchymal branches are involved. So in renal artery, we have discussed that anything from the main renal artery to the interlobular artery can be involved. However, main involvement is with the arcuate artery and the interlobar artery. So its pathogenesis is infection causing immune complex formation that will go and sit in these vessel walls and stimulate inflammation. So it is equally predominant in males and females, and it is mostly seen in areas where HBV is endemic, and the onset happens between 40 to 60 years of age. Okay. Now, clinical features. This picture is adapted from Feehales. I'll tell you what I can see in this in a minute. Okay. So they present with mainly constitutional symptoms like fever, arthralgia, something like a serum sickness like syndrome. They can have peripheral neuropathy because the epineurial arteries can get involved, and it can cause mononeuritis multiplex. Gastrointestinal complaints can be 50% of patients present with pain, and renal involvement, renal infarction and hemorrhage. So here you can see this microaneurysms that are forming. These are inflammatory part of the vessels which are forming aneurysms. Okay, this is what you get if you do a renal angio. And in skin, you are going to see skin nodules. Okay, so these are nothing but the necrotizing arteritis which has formed skin nodules. So renal infarction or hemorrhage happens when these blood vessels rupture or they thrombose. Now, like I told, the pathology, it might involve main renal artery to the interlobular artery, but common is arcuate and the interlobar artery. Okay, So what happens is whichever part is getting inflamed, that will get necrosed. So it becomes segmental fibrinoid necrosis. That will cause thrombosis or hemorrhage, okay? And pseudoaneurysm will form. Why pseudoaneurysm is, this wall gets eaten away, okay? It's not dilatation of the wall. This wall gets eaten away, and then whatever the inflammation is surrounding this wall will encase the blood vessel, okay? So this wall is actually eaten away, and the blood is in the inflammatory wall. So that is why you call it as a pseudoaneurysm and not true aneurysm. So these are the pseudoaneurysms that you are seeing in the probably these are interlobar vessels, okay? Now, the close differential is microscopic polyangiitis. How do you differentiate? One of the important things you have to remember is, if the patient is presenting with the features of glomerulonephritis, that is, if the patient has urine routine showing proteinuria, RBCs, then you have to rule out polyarthritis nodosa. Okay, so in the last INSS, there was a question where patient is HBV positive and patient is presenting with glomerulonephritis. All of this could be features except. So except answer is polyarthritis nodosa, because in the urine routine that patient had glomerulonephritis involvement or glomerular involvement. Okay. So clinical feature, you're going to see microaneurysms by angiography, in polyarthritis nodosa, rapidly progressive glomerulonephritis in microscopic polyangiitis, pulmonary hemorrhage again in microscopic polyangiitis, renovascular hypertension in polyarthritis nodosa because it involves the major renal artery and its branch. Peripheral neuropathy is seen more commonly in PAN than in microscopic polyangiitis. Positive hepatitis B serology, it is uncommon, but you can find it in polyarthritis nodosa when compared to microscopic polyangiitis. Positive ANCA is rare in polyarthritis nodosa, but it is frequent in microscopic polyangiitis. And relapses are rare in PAN and it is frequent in microscopic polyangiitis. So you don't have to remember all these things. Just remember, if the glomerular involvement is seen, then it is microscopic polyangiitis or ANCA vasculitis and it is not polyarthritis nodosa. Now, natural history and treatment, it generally shows high mortality without treatment. Treatment is if there is a life-threatening organ complication and there is no HBV, then you have to give cyclophosphamide and steroid, okay? If there is HBV, you have to start the antiviral therapy along with this, okay? And if in a less severe disease, you have to give only steroid. Next is Kawasaki disease. Kawasaki disease is also a medium vessel vasculitis. How do you differentiate between Kawasaki and polyarthritis nodosa is, there is mucocutaneous lymph node involvement in Kawasaki disease. So it presents as acute febrile illness, most common in children of age 2 to 3 years, consider less than 5 years. So as adults, as physicians, we generally don't get to see this disease. Then it generally causes mucocutaneous syndrome. So mostly it affects the coronaries and renal involvement is rare. This you have to remember, okay? Renal involvement is not common in Kawasaki disease. So mucosa, you get to see red mucosa, the classic strawberry tongue, and lymphadenopathies and cutaneous rashes, reddening of the palms and soles. So all these are the features that you can see when this child presents with fever, okay? And coronaries can get affected, causing coronary aneurysms. Infectious agent, environmental toxins, all of these are considered in pathogenesis of Kawasaki disease. Now, clinical features, like I said, it's mucocutaneous lymph node syndrome. Don't remember the classic strawberry tongue. And peak of arthritic lesion happens at 1 week. Okay, so at 1 week, the peak of lesion, that is if it's involvement of coronaries, all that happens in 1 week, and generally it starts recovering by 1 month. Okay, and it is the most common cause of childhood myocardial infarction because it involves the coronary arteries. So necrotizing inflammation in the blood vessel causes edema and then fibrinoid necrosis. Okay. But however, you see that edema is more than fibrinoid necrosis in these patients, unlike in PAN where necrosis is more than edema. So here they are not that severe, causing that severe necrosis. Okay, that's why they recover easily. And steroids should be given carefully because they increase the risk of aneurysm in Kawasaki, and it's a self-limiting disease. So IVIG and aspirin is the treatment of choice. So it's important to differentiate it from other vasculitis because if you give steroids in Kawasaki, it can cause coronary aneurysms. Okay. Next, coming to the large vessel vasculitis, which is Takayasu and giant cell arteritis. It is nothing but chronic inflammation of the aorta and its major branches. In giant cell arteritis, it's most commonly extracranial branches of the carotid. In Takayasu, it is aorta and the arteries supplying the extremities. Okay. Giant cell arteritis is the most common type of vasculitis. Now, these are some differences between the both. Takayasu is mostly seen in Asia. Giant cell is mostly seen in Europe. Gender, it's more common in female. In Takayasu, it's 9 times more common in female when compared to male. Whereas in giant cell, it is 4 times more common in females when compared to males. Age is generally, Takayasu is seen less than 50 years, somewhere in the 10s or 20s. But giant cell is seen more than 50 years. Involvement is in Indians, mostly you see abdominal aortic involvement. In others, like in Japanese, you see more of aortic arch involvement. In Africans, you see more of infrarenal aorta involvement. Whereas giant cell arteritis, we know it causes mostly the extracranial branch of the external carotid artery is the most common involved. Clinical features is like if the renal vessel is involved, you're going to hear a renal artery bruit. There is going to be reduced pulse in the limbs, and because of reduced blood supply, there's going to be claudication, renovascular hypertension. But here, if for example the temporal artery is involved, you're going to have headache, jaw claudication, and other extracranial branches like ophthalmic artery, there is going to be blindness. Okay, polymyalgia rheumatica is an important association, which is nothing but persistent neck pain and generalized body ache in these patients, which is seen in a very high proportion of patients with giant cell arteritis. Renal involvement is rare. Okay, like in Kawasaki, renal involvement is rare in giant cell arteritis. Now, you do CT and MRA in these patients, you see structural changes like there is going to be inflammation, stenosis would have happened. So that you're going to see. If you want to see functional changes, that is inflammation, then you have to do PET CT. Okay. In the active phase, there will be inflammation, and in the chronic phase, there's going to be fibrosis. Treatment is steroids, because once it reaches chronic phase, there's nothing much you can do. In the active phase, you can give steroid. Okay. If renal vascular hypertension is there, it is involved in one vessel, then give AC inhibitor. But however, if both vessels are involved, then patient might have to undergo surgery for renovascular hypertension, or patient might have to undergo angioplasty. Now, this is the synopsis of all different types of vasculitis. Just a quick revision. So, we know this small vessel vasculitis was classified into ANCA and immune complex related. So, ANCA is a necrotizing vasculitis with few or no immune deposits. So, that is why it was called as pauci-immune, right? And it predominantly affects the small vessel. It can have either MPO ANCA or PR3 ANCA, where MPO and PR3 are the antigens, right? So, in that there were 3 types. Microscopic polyangiitis, where necrotizing glomerulonephritis was common. Pulmonary capillaritis also can occur. Granulomas are absent. That is very important. So, you're not going to see any cavity in the lung or saddle nose, or a collapsed nasal septum. You're not going to see all these things. Okay. Next is granulomatosis with polyangiitis or vaginous. Upper and lower respiratory tract involvement was seen, which is common. Necrotizing glomerulonephritis also occurs. In EGPA, which is Churg-Strauss, you see eosinophilia and asthma, which is eosinophil-rich necrotizing granulomatous inflammation of the respiratory tract. It can involve CNS and it can also involve GIT. Okay, so this is the second section, which is immune complex. So, among immune complex, you see vasculitis with moderate to marked vessel wall deposits of immunoglobulin. There in ANCA vasculitis, you saw that there were no deposits of immunoglobulin, but here there are deposits of immunoglobulin, okay? And glomerulonephritis is common. So, in anti-GBM disease, that is the first example, you see the antibody, that is anti-basement membrane autoantibodies that are deposited in the GBM. Lung involvement can occur and pulmonary hemorrhage can occur. The details are in the anti-GBM chapter. I'm not getting into that. I know it's already like too much for you to take in, so I'm not getting into that. Renal involvement is GN with necrosis and crescents. Okay. Second is cryoglobulinic vasculitis, where you see cryoglobulin deposits in the small vessels. The structures involved are skin, glomeruli, and peripheral nerves. IgA vasculitis, we are going to see IgA deposits. The structure involved are skin, joint, kidney and gut. Okay. And hypocomplementemic urticarial vasculitis or anti-C1q vasculitis. So you're going to see hypocomplementemia, you're going to see urticaria, anti-C1q antibodies, positivity, glomerulonephritis, arthritis, obstructive pulmonary disease and ocular. So obstructive pulmonary disease, patients are going to have glomerulonephritis and C1q antibodies. Okay, so you remember structures which are 2 in number, that is eyes, lungs, kidneys. These 3 things are getting affected in hypocomplementemic urticarial vasculitis. Now coming to medium vessel vasculitis. In medium vessel vasculitis, you see in polyarteritis nodosa, what we see is it is a necrotizing arteritis of medium or small vessel without the glomerulonephritis. That is important, and it is not associated with ANCA. In Kawasaki disease, it is also involving medium or small arteries but with mucocutaneous lymph node involvement. Okay, coronary arteries are often involved. Aorta and large arteries may be involved, and it usually occurs in infants and young children. Okay. Now coming to Takayasu, which is large vessel, which is granulomatous. Aorta or its major branches can be involved and is seen in less than 50 years of age. Whereas giant cell arteritis is also granulomatous arteritis. It is seen in more than 50 years of age. Aorta and its branch, that is basically the extracranial branch of external carotid artery, is what is majorly involved. It is associated with polymyalgia rheumatica. Now coming to the last section, which is a breather to you that this laborious topic is getting over. Let me just brush through. Okay, just remember before exam, go through this quick revision section. Okay, if you do not have time to revise, come back, swipe through the last few minutes of the session, and we'll be giving you the timer also when each session will be there. So come to the quick revision section and then go through this. Okay, so induction agents used in ANCA vasculitis, we know glucocorticoids are used. Along with glucocorticoids, it is cyclophosphamide or rituximab. Okay, which are the trials in induction? So the trials which studied about rituximab is rituxivas trial and rave trial, right? So rituxivas trial showed that 4 doses of rituximab plus 2 doses of cyclophosphamide was equal to giving cyclophosphamide plus glucocorticoid in severe disease, right? And in rave trial, it was seen when creat is less than 4, Ritux when used is helpful in relapsing disease and PR3 positive disease. So these 2 are about rituximab. Then came the Cyclops trial. Cyclops trial was about IV and oral cyclophosphamide. So IV cyclo had less dose, more relapse, right? But oral cyclophosphamide had more dose and less relapse. Next, coming to MYCYC trial, which showed that in non-life threatening MPO disease, MMF can be used as induction like cyclophosphamide. Next is Pexivas trial. Here I will write here. Pexivas trial, which showed that low dose glucocorticoid is same as high dose glucocorticoid when used in induction in patients with GFR less than 50. The other inference of Pexivas trial was that plasmapheresis has no role in preventing death or renal failure, which is ESKD, or pulmonary hemorrhage. Other trial was Advocate trial, which showed that avacopan, which is an oral C5a inhibitor, this drug can be used as a glucocorticoid sparing agent. Okay, so these are the trials that we read in induction. Rituximab versus cyclophosphamide in induction. So rituximab we know that we used in extremes of age group or when fertility needs to be preserved, in PR3 positive disease or in GPA. So these are the conditions in which Ritux was preferred. Cyclophosphamide is if it is life-threatening increase in creatinine, like patient is requiring dialysis, all those severe conditions, we use cyclophosphamide. IV versus oral cyclophosphamide in induction. This we discussed already. IV is low dose high relapse. Oral is high dose and less relapse. Okay. Indication for plasmapheresis in ANCA-associated vasculitis, 3 important indications. If serum creat is more than 5.7, if there is pulmonary hemorrhage, and third important condition where it will be required is this dual or double positive disease, where it is ANCA plus anti-GBM. So here we give 7 sessions in 14 days. In pulmonary hemorrhage, it is till the hemorrhage stops. Here you give till 14 days or till anti-GBM antibody become negative. So here it is continuous, here it is continuous. Now Pexivas trial, it proved 2 important things. It's basically to evaluate the effectiveness of plasmapheresis in vasculitis. When GFR is less than 50, low dose glucocorticoid is equal to high dose glucocorticoid, and plasmapheresis is not useful. Okay. Drugs used in maintenance therapy in ANCA vasculitis, we know 2 important drugs are used. One is rituximab, another one is azathioprine. Okay. So these are the 2 drugs. Now patients who have higher risk of relapse, you can simply remember if it is PR3 or if it is Wegener's or upper respiratory tract involvement or low dose immunosuppression or which had to be withdrawn or glucocorticoid withdrawal. So all these things form high risk for relapse. So these 3 things you can remember, it has been asked as a question. Okay. Ritux versus aza in maintenance. Ritux again you give in the same group of people, in PR3 positive, in Wegener's, in relapsing disease you consider giving rituximab. So aza therapy you give in patients who have baseline IgG less than 300, that is already the immunoglobulin level is low. You do not want to further depress this thing, that is IgG, and if the patient is HBsAg positive, because HBV might get reactivated. Renal manifestation of PAN, we know it is renal infarction or hemorrhage. There can be renovascular hypertension, and when you do a CT angio, you are going to find pseudoaneurysm. Okay. Thank you friends. I hope I have helped you in understanding this topic. So this topic is a sure shot in exam. At least 3 to 5 questions will be picked from vasculitis. So please go through the part 1 and part 2 couple of times and then you will definitely get a hang of it. Till I meet you in the next class. Bye bye. Happy studying.